Thank you very much อย่าดุผมนะครับอาจารย์ Okay, please my slide. Okay, thank you very much. Now I will touch a bit about the superior capsular reconstructions. 4 years ago, we had a chance to visit Mihata. If you remember, we invited him to our TOSM meetings. So he proposed using the IT band to reconstruct the superior capsule. Well, initial response to that concept is a little bit awkward, like you put a dead tissue in there, how will it work? So I didn't interest in it at all until one day during my practice, I see this lady, 56 years old, 8-month shoulder pain, and she has a pseudo paralysis. You see her shoulder could lift only that. And well, this is her x-ray. And she's 56. Oh, sorry, the CMRI. So it's quite a bad tear, isn't it? And okay, what is next for her? What should we do? A partial repair, reverse total shoulder tendon transfer. You can't really reduce that. So then the superior capsular reconstruction come up to my mind. So the first indication doing for superior capsular reconstruction is a pseudo paralysis with superior instability, who is a poor candidate for reverse total shoulder. This lady, obviously, she is. So this is what we did for her. So we debrided, refreshed the bone end on glenoid and on the humeral side. We took the IT band and folded 3 times, made like about 8 millimeters thickness. And we anchor the 2 anchor on the glenoid. We use the nail visor portal to use that. So these 2 anchors will act like a pulley to pull the graft, the IT band graft. We insert the anchor for the repair too. You see, you have 4 anchors inside the joint now. So then we like kind of a cable thing. Use a suture to pull the graft inside the joint, like that. So after we sit the graft inside the joint, we start to tie on the glenoid side first, and then I repair the IT band to the posterior structure, which is infrascapular, infraspinatus, and subscapularis in the front, and then I fix the graft. This is a final picture. It's cover all the humeral head well with the proper tension. I said proper tension. Remember how I will tell you how we do that. It is. And this is 4 month post-op. This is 8 months. So it helps. She has no pain. She's satisfied with the result compared to the pre-op, which is on the right. The second indication for doing a SCR, if you have a radiographic or arthroscopic evidence of proximal migration and acromial humeral fulcrums with preserved range of motion. This will be very good for the pain relief. You can say like it is almost like a balloon things. This is a 75 years old. She has a bad shoulder pain. You can see he can't really lift his left shoulder because he's pain for 5 years. So you see X-ray and MRI. I think he will probably be one of the candidates for doing the reverse total shoulder, but he can't afford the expense. So okay, after discussion, okay, let's try repair. So see that it's not that good. His humeral head start to degenerate. I would like to do the reverse, but well, this is my situation in Chiang Mai. Not everyone have money, so in no way we can repair that. Again, so we did the same things. IT band. Now I start to do a little more proximal because you give you a thicker size of the graft. I don't use a tune, I just use my finger to push the graft in. And you see that the nail visor portal shunting them in like that. So this is the same things. And then we just tie it down like that. Okay, this is a final pictures with the proper tension again. So doing an SCR, less predictable result when you have the patient who is a revision surgery, or you have pseudo paralysis more than 6 months. It's not and contraindication, just less predictable result. Why? How that SCR works? So if you got a SCR, First is like a buffer to reduce the humeral head down, so it's improved shoulder stability, it's increased the pain. Then from that, it results in a better deltoid functions. And with connection of the infra and subscapularis, it creates the restore force couple that actually help to depress the humeral head and lift the shoulder. Tip and trick in doing SCR: first, you need to have intact the front and the back, so subscapularis, if it's torn, you have to repair it. Infraspinatus, usually it is partial repair. You have to get rid of the bicep, either tenotomies or tenodesis. You need to do a chromioplasty because it will give you a good space. It will decrease the abrasion of the graft. So arm position during doing SCR, Mihata did a study and he found that if you abduction 30 degrees, that decreased the superior translation and subacromial contact pressure. So the lateral decube, that's probably the ideal position of doing an SCR. Graft preparation, well, you can try several thickness of the graft, and they found again that thickness of the graft 8 millimeters is the best graft in terms of the superior translations. And effect of side-to-side repair. If you remember, after we put it in, we repair to the infraspinatus and subscapularis. Well, the study support that after you repair it, it helps to decrease the superior translation. So that are three things you need to consider during an SCR. Clinical result, Mihata followed 2 years and he get a very good range of motion improving, and also the score improved from 24 to 93. Of course, out of his 311 cases, there's some complication, but most are minor, not a major, which is not bad at all. You have any other option of doing an SCR? If you read more and more, you see in American groups, they use a dermal patch, low graft. So I think the reason for them is just easier because you don't have to donor side mobilities. And it's thin, but he said it's helped in about 70% of the patients. It improved the shoulder score. So which one is better? So there is a study report that compared tensor fascia lata and the dermal graft named Arthroscopic. They found that with the tensor fascia lata, it stabilized the shoulder better in terms of a superior translation. This literature still fairer of the ITB. So what else can be an option? This is our friend Yang Soo Kim. He came to Tossum a few years ago. So he used a biceps to create the SCR. So I did that recently because this is very interesting. You see these patients, 61 years old male, X-ray, MRI. This is not too bad. I think it can repair it. So I didn't prepare for the graft for the SCR. And in fact, when I came in, I could not repair this case. So, and you see that's a badly torn subscap. So I deal with subscap first. Okay, after I release subscaps, so this took me an hour to repair subscaps in this case, and then you see the biceps. So this is always a question. We always talk about bicep is a pain generator, and now we're using the bicep. So there's still no good evidence to support. So I release the bicep and I prepare the insertion of the TT, and then I stitches the bicep with through the suture anchor. So like that. So by original technique by Yang Soo Kim, he still maintained the bicep. He didn't cut the bicep. But I don't think it's a good way because it actually create an abnormal biomechanic, pull the bicep to the back. I don't like it, so I cut the bicep. And then after I cut the bicep, I tie everything down. That is after I do the partial repair and SCR, this is some hole in the front, and that's a subscap that has been repaired. This is not too bad. So is there any evidence? There is a cadaveric study compared to the bicep SCR with the tensor fascia lata, and they found that it's comparable to the IT band with the biceps. So probably it is one of the options. And when I found out there's a Chinese way to do it, it's exactly the way what I did to these patients. How scientific is the SCR? If you look at the literature search, you insert the word like that, it's come up with like 52, which is not too many. And you look at the clinical result, it's only 4 or 5 papers. It's not a long-term follow-up. So this is something you have to wait and see more and more. By summary, can SCR be another option? First, a proper select case. We're talking about these 2 indications, pseudoparalysis, we should not do SR, reverse total shoulder, radiographic evidence of the humeral head migration. And is it proved by biomechanics study? I don't want to go back to talk about this again. I talked about that already. And lastly, there is some support, clinical data, but this is something you have to looking forward to read more and more. Thank you very much for your attention.